look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
So good afternoon, everyone. I hope everyone's had a good lunch. It's fantastic to be here speaking with you today. It's really a nice change to actually come and speak to patients at a conference rather than speaking to other professionals. So that's really nice. And today we're going to talk a little bit about managing devices. I'm going to talk firstly about the practical considerations with devices, and then Jenny will tackle a bit more of the psychological side. Before we start, just to kind of gauge the audience, how many patients in here or people in here have got devices already? Fair few. And is anybody considering or waiting for a device at the moment? Yeah. Anybody not got devices? Just, yeah. Fantastic. So there's a real good mix. So that's really good. So my background, I'm the head of devices at the Queen Elizabeth Hospital in Birmingham. So we're a big device centre with lots of different cardiomyopathies treated there as well. My background, I'm a cardiac physiologist, clinical scientist, or device technician. We're known by a lot of different names, but we're the people who are programming your device at the time of it goes in, and we're the people who will see you in the follow-up clinics, do all the tests on the device, do all the reprogramming, and manage you in the first instance. So that's my background. So firstly, just to introduce all the different types of cardiac devices to everybody. Some people might know about them, some people not. So we'll just do a very quick summary of each of these different devices. So there's four main types of devices, ILR, pacemaker, ICD, and CRT. There's some acronyms in there that I'll go into in a moment. So firstly, we have our ILR, implantable loop recorder. So this is the simplest type of device that we have. This device doesn't deliver any treatment, it doesn't deliver any therapy. It's a diagnostic tool. Some people might have had heart monitors on before. These are patches that sit on your chest. They're looking at your heart rate and rhythm, looking at an ECG over a period of 24 hours, 48 hours, over a week. But sometimes your symptoms might not happen over that time period. They may be more sporadic. And these devices can be implanted just underneath the skin in your chest. And they can look at your heart rate, heart rhythm over a much longer period of time, such as up to 3-4 years. So if your symptoms are quite sporadic, hopefully we can try and catch and see exactly what's going on. Now it's just a recorder, it doesn't do anything to treat, it just looks for funny abnormal heart rhythms, abnormal heart rates. And it also allows you to record if you have symptoms so that we can see exactly what's going on. The next device we've got is a pacemaker. And now this is the simplest of the treatment devices, as I'll refer to them. Now a pacemaker is a metal box with a battery inside and a whole load of different electronics connected up to some electrical wires that are fed down into your heart itself. Now a pacemaker is there to try and stop slow heart rhythms. It doesn't work all the time, it monitors your heart, and if your heart goes too slow, it delivers a painless electrical stimulus that helps your heart beat. And it's as simple as that, really. The next device we've got is an ICD, an implantable cardioverter defibrillator. You might see out on the streets now, there's defibrillators popping up everywhere. You see them outside pubs, train stations, shops, libraries, all over the place. And this is fantastic because defibrillators can save lives. If patients or people go into a very fast heart rhythm in the bottom chambers of your heart, the heart's beating so fast the blood is not getting around your body, and it's termed as a cardiac arrest. And the only way to try and get you back into a normal rhythm and save your life effectively is to deliver a very big electrical shock, which stuns the heart, resets it, puts it back into a normal rhythm, and helps you to survive. So the defibrillators are great, they're out there, they're all over the place, but they're not next to you, you don't have to carry one with you. This is something that can go inside your body, if you're at higher risk of one of these funny heart rhythms, dangerous heart rhythms, or if you've had one of these dangerous heart rhythms before, survived a cardiac arrest. So they're implanted inside you, they monitor your heart. Hopefully it never happens, but if it does, if your heart goes into one of these horrible rhythms, cardiac arrest, it delivers a big 900-volt electrical shock to reset it. It sounds brutal, but it saves your life at the end of the day. There's two types. One is very similar to a pacemaker and comes down the veins into your heart directly. And one called a subcutaneous ICD sits on the outside of your body, sits just underneath the skin. We'll go into that in a little bit more detail later. The final type of device is CRT, cardiac resynchronization therapy. Now this is a pacemaker or defibrillator device that is specifically designed to help with heart failure. So when the heart pumping function is reduced, so it's not pumping particularly efficiently, and the heart is beating different rates in the left and right side of it, this device delivers electrical pacing to try and pace at the right time to make it pump efficiently and synchronously. And that helps to improve your function and help with symptoms like breathlessness. It can have a defibrillator component in as well, or it can just be a pacemaker. The idea behind it is it's trying to improve that heart function over the long term. So implanting these devices. To implant them, it generally requires a form of surgery. The surgery differs slightly depending on the device, but it's essentially a form of keyhole surgery. And it's performed in an environment like this, which is called a cardiac cath lab. When you look at that picture, it looks like there's lots going on, there's lots of equipment, it can be quite scary. But the reason for it is that we have an X-ray camera. And the X-ray camera allows us to visualize where the leads and things are going into your heart through the keyhole without us having to open up your chest and make it a lot more invasive. So surgery. So there's different types, different techniques for the different devices that we put in. So we'll start with the simplest first. So the implantable loop recorder, this is that diagnostic device that's monitoring your heart rhythm, looking for abnormalities. So this device is probably the easiest procedure that we do. And it's implanted using an injector. So it's a bit like a syringe. It's preloaded in a syringe. We make a small cut on your skin, just in your chest here. It's about a centimetre wide. We put the injector in and we just inject that device into the skin. It's very small. It's about almost 2 inches long, very, very tiny. And they've gradually got smaller and smaller over time. People who may have had one of these in the past might remember it being a memory stick size. The procedure itself takes about 5–10 minutes. It's very straightforward. It's done under local anaesthetic, and generally you have it done and you can pretty much walk away from it straight away now. The next type of device, and I term this as a transvenous device, and that means that the leads are going through the veins directly into the heart. So that's pacemakers, that's ICDs, defibrillators, or CRT devices. So with these devices, we make a small cut just below the collarbone, and that's where we create a pocket where the actual box will sit, the box that houses the battery and all the electronics. And then we use a porthole where we put some leads directly down the veins into the heart itself, so that we can literally pace that heart muscle straight away. So these procedures generally take about half an hour to an hour. They're fairly quick. They're fairly routine these days. And they're generally done under local anaesthetic, usually with sedation to make you a bit more comfortable. Now the final type, I mentioned earlier about this subcutaneous ICD. So transvenous devices, the devices that go through the veins, they're very, very good. We've been using them for 50, 60 years now. We've got a lot of experience with them. The problem with those is any type of surgery that we have, there's a risk of infection. Now an infection on a pacemaker with a lead that goes directly down into your heart can cause problems in the future. Not for everybody. There's a very small risk, but it can happen. So how do we get around this? Well, we have a new type of device. I say new, it's been around for about 20 years now, but this new device sits just underneath the skin instead. The box sits under your arm on the side, and the lead sits along the breastbone. And this is implanted in a very similar technique, but without the need to go through veins and directly into your heart. And that's a different type of device. It's not perfect for everybody, because it's on the outside of your heart, it can't always see the heart signals very well, particularly when you think about the leads that go directly into the heart. They can see the heart exactly where it is. They can see what's going on at the heart level. So we do some screening for these types of devices, and they're not suitable for everybody, but it's another option. So you've had your surgery. What happens next? And this is where we get a huge number of different questions. So I'm going to start just with recovery. So the procedures, they take an hour or so. Generally nowadays, they're done as a day case procedure, so you can come in the morning, go home the same day. Once you go home, what do you do? What do you expect? So recovery can take a couple of weeks, up to about 6 weeks. Depends a little bit on the individual, because it can change person to person. So when we put these leads in, we create a little pocket, we break down some tissues. It can be a little bit painful, a little bit sore, certainly for the first week, 2 weeks, sometimes more, sometimes less. It just depends on you as a person. But generally within the first week, 2 weeks, 3 weeks, people start to feel a lot better. It sounds really foreign. You've got this big lump of metal sat in your body. I'm sure that's quite not the easiest thing to kind of get your head around. But generally we find most people get on with it quite well. It sits very nicely, and over time they almost forget that it's there, which is fantastic, and that is the ultimate goal. Do's and don'ts. Well, we want you to live a normal life. You will want to live a normal life. We don't want this to become a burden. We don't want this to be forever there reminding you that you've got this heart condition. So most things you do in life, absolutely fine, with the exception of a few small things. And that includes things like contact sports, deep scuba diving, arc welding, things that use a magnet. So anything that uses a magnet can still be used, but we just recommend that they're 6 inches away from the device because they can interfere with some of the electronics. You can still use smartphones, you can still use your microwave, you can still do all the things that you do normally. You just have to be a little bit mindful that it just needs to be 6 inches away from where that device is. So just no phones in top pockets and things like that. Otherwise, there's not really many restrictions. If you've got any particular or specific questions, speak to your local device centres because we encounter all kinds of different questions, and we have access to the companies that make this who do a lot of testing on lots of different types of machinery. So we'll be able to advise you in a bit more detail. What about follow-up? Okay, so you have this device in, we don't close the door, we don't say see you later, that's the end of it. We are here to help you, and we're here to help you for the length of time you have this device, which can often be the rest of your life in most circumstances. So your follow-up centre, you can speak to us at any time, ask questions, physiologists, nurses, doctors, we've got a huge team there to look after you, and we want to answer your questions, we want to help you, we want you to get back to normal life. Typically, in the past, we've followed you up in a clinic where we have a big computer that will talk to your device and do various tests and programming on. Nowadays, we've moved more towards something called remote monitoring, where we can issue you with a box similar to these pictures here. Some devices, you can actually have an app on your smartphone now, and that just sends data automatically through to us at the hospital over the internet. So it takes away that need to come to the clinic every 6 months, every year. It's much more convenient for yourselves, you don't have to pay for parking, but also if you have a problem at home, you haven't got to wait to be seen in clinic, you haven't got to go to A&E, you can call us up, say I've sent some information to you, and we can advise you there and then. So that is a really good step forward, and that technology is evolving as time goes on, and in the future they're all going to be smartphone-based, app-based, or very simple to use. So just going to talk a little bit about cardiac arrest and defibrillators, because these are the devices that often cause quite a lot of anxiety with patients, and there's a lot more questions around those because of the type of therapy that we give. So I mentioned earlier, we have fast heart rhythms that come from the bottom chambers of your heart, and that term cardiac arrest, it's a scary term, but I'm just going to hopefully visualize this in a little bit more detail. So in the top left-hand corner, you can see an ultrasound scan of a heart. It looks a bit strange because the heart's upside down. So if you turn it around, at the bottom, you have 2 chambers in the top, the atrium, and the top port, you have 2 chambers at the bottom, the ventricles. The left-hand side is a normal beating heart. So the heart is pumping nice and efficiently, it's getting blood in and around your body. On the right-hand side, this is somebody who's gone into cardiac arrest. So they're in a very, very fast heart rhythm. It's not like casualty that you see on the TV, where you get a flat line. you generally have a very fast heart rhythm, but it's so fast the blood is not getting out and around your body, and the heart looks a lot like this. So the blood is pooling, the heart's just kind of quivering, and it's not getting the blood to where it needs to go. So how do we stop this? How do we save the life? How do we prevent it? This is where the defibrillation comes in. And we deliver that big electrical shock, which resets the heart rhythm and gets it back into normal, gets the blood pumping normally. So a little bit more about that. We often get lots of questions, and unfortunately I don't have a device, so I don't know what this feels like myself, but there are people out there that do. And there's lots of help and support to help with that. I'm sure Jenny's going to speak a little bit about this later as well. So will I feel it? What do I do? What happens next? Well, just to say, this isn't going to happen with everybody. Not everybody who has a defibrillator is going to have a cardiac arrest. The chance is fairly low. But the reason you're having the defibrillator is because it's slightly higher than the average person walking around. Usually it's around 5% over 5 years. It differs slightly depending on condition and things that have happened in the past. But it's actually low. We're talking below 10% chance of this happening. So the key is don't go around thinking, oh my God, this device is going to just give me an electrical shock all the time, because generally it doesn't. And we have lots of people who have these devices and don't have a shock. Will I feel it? Now I'm told it's like being kicked in the chest by a horse. That doesn't sound very pleasant. I know that, but I'm just trying to be honest. The thing is, if you have one of these rhythms, there's a very good chance that you're going to black out, you're going to be unconscious, you're probably not going to feel it. Actually, really surprises me, but a lot of people come in and say, well, actually, I didn't feel anything. I don't know how that happens because I've seen it and it looks quite painful, but it does. And that's why. And others do feel it and it's quite painful. But the key is this device is trying to save your life. It's an end thing. We're not relying on this. It's an end stage thing. This has happened. We've got no more attempts to try. Let's try something to get you back to life. And that's what it's about. So what happens next? Well, if you have one of these shocks, the best thing to do, take a minute, catch your breath, and then decide on how you're feeling. If you're feeling unwell, if it's happening continuously, then just call 999, come into hospital, get medical advice. And nobody is going to stop you or tell you that you've done the wrong thing by doing that. Even if you're worried, concerned, just come to hospital because we can see you, we can help. If you're feeling okay, you're feeling well, actually you don't need to panic, you don't need to come to hospital. You can send some stuff for your remote monitoring, or we can call your clinic and we can advise you and we can say, okay, we can see you at the earliest opportunity. We do want to see you, but we haven't got to panic here. Or we could say, actually, no, just come to A&E. We get two types. We get appropriate and inappropriate shocks. Appropriate means that your heart's gone into that rhythm we're trying to treat. It's done its job. It's a machine at the end of the day, so sometimes it can get it wrong. So you can have shocks that are not caused by this fast heart rhythm. It's a machine. It can get it wrong, but that rate is very low. Generally nowadays, it's around 2% chance of that happening. And that's 2% of having a shock, which is, again, of 2% of about 5%. So it's a very low chance of that happening. Now, the biggest thing, the one that we always ask questions on, and sometimes we have some heated discussions around this, is driving. So when you have a device, there are implications with driving, and it's not us that creates that, it's the DVLA. So it's regulations that we have to abide by. Depends a little bit on what device you have. For example, if you have a pacemaker, you only have to stop driving for a week after your procedure, and then you can go back as normal. You're probably protected better than all of us out there. If you have a defibrillator, it depends on why you've had the defibrillator. If you've had it for a previous cardiac arrest or a previous fast heart rate, then it's usually a 6-month restriction on your driving initially, and then you can go back to driving as normal. If you've had it because you're at higher risk of having one of these rhythms, then it's a month off driving initially, and then you can go back to normal, okay? If you were to have shocks in the future, there are driving restrictions, and that can vary between a month up to 2 years. Now that sounds horrific, and most people really don't like it when that happens, but there's reason behind it. It's basically, if you've had one of these shocks, you've had one of these fast heart rhythms, there's a risk that it's going to happen again. And when it happens, you can lose consciousness, and you may crash into somebody else, you may crash and harm yourself. So it's all to protect you, it's to protect the public. There is reasons behind it. Your clinic will be able to guide you on this and support you with this, and often 6 months is usually the maximum because there's things that we can do to try and help. But yeah, there is driving restrictions. It is important that you know and are aware of that. At the end of the day, if you don't have a device, you're still going to have some driving restrictions placed on you as well. So it's just one of those, unfortunately. And finally, just talking about end-of-life care. Now, this is not something that most people want to talk about at this time. It's not a nice subject to talk about, but it is something that's important to at least be aware of. Because when it comes to the end of life, you've got, at the end of the day, if you have a defibrillator, you have a device that's there to give you electrical shocks to bring you back to life. At the end of stages of life, that might be futile. You may end up with lots of shocks. It may be entirely inappropriate. And it's important to say that defibrillators can be turned off at any point, and they can also be turned back on. It's a switch, we just turn it off, we turn it back on. So it can be a bit of a fine act of when we do this, whether we do this temporarily, whether we do this permanently. But often we just think about things at end of life, and sometimes it's appropriate to turn off the defibrillation side of the device because you don't want to be getting electrical shocks when your long-term prognosis is poor and you're thinking a little bit about palliation. It's not a nice subject, but it's just something to be aware of. It's reversible, so if we turn it off, we can turn it back on again. It's device dependent, so for pacemakers, CRTs, we don't turn it off. It's purely for defibrillators. Okay? And the key question is this treatment still worthwhile? Because I might have had this device when I'm 15 or 60 or 45, and yes, I want to carry on living. When I'm 80, 90, I might not want to get electrical shocks and have to be resuscitated and things like that. And it's just having that awareness that these things can be turned off. If you suddenly decide, actually, this is too much for me, we can also turn it off. And just have an open and honest conversation with your healthcare team because they'll be able to help you make decisions on this and discuss it in a bit more detail. Just going back quickly, there is actually a guide by the Resuscitation Council online. It's a really good patient guide that just goes through all of this stuff in a little bit more detail. So just a reference point for you there as well. So the form on there is a respect form. So this is generally what patients fill in if they want a do not resuscitate order towards the end of their life. Sorry, I didn't explain that. So this is a care plan. So when you reach palliation, you can decide that actually you don't want to continue with resuscitation. And that's becoming quite a hot topic nowadays. And this is an example of the form that you would fill in. So turning a defibrillator off is not a quick, right, I'm going to do it today. It's a discussion. It's a bit of a form-filling process. It's about talking to your doctors, talking to your family, talking to yourself to make sure it's the right decision for you. Yes, sorry.
This form is really only for, like you're stopping them from, what's the word?
Performing CPR, yes.
Performing CPR, but we're not stopping them from giving you antibiotics or
No.
any other thing.
No, absolutely. That is key. Yeah, that is absolutely key. So there's lots of different processes that take place towards end of life. This is an example of one of them in terms of the CPR. And it often this kind of starts, if you have one of these forms, it facilitates those questions about what to do with your device then as well. And it may open the door to other things, or it may just be that alone.
So you shouldn't do a form like that? You shouldn't have that all written out for people?
No, we don't. We don't routinely. This is something that happens if you were to be referred towards palliative care. Sometimes if you come to hospital and your prognosis coming out of hospital is not good, they may discuss it at that point. But it can happen at different points. Some people may decide, actually, I don't want this. It's a really long discussion about CPR, defibrillation. It's quite a hot topic at the moment, and I'm sure we can, if you've got questions, we can talk about it in a bit more detail after, absolutely, or with your own healthcare teams. It is a difficult subject to get your head around. So just to summarise, get the slide to work right. So we've got 4 different types of devices. They all do different things, and they all have their own intricacies, but they can often be for different people at different times during their diagnosis and condition. So we have our ILR, which is a diagnostic tool. It looks for abnormal heart rhythms or abnormal heart rates, and it can be used to diagnose things that may need treatment in the future. Pacemakers, small electronic device that goes in your chest, leads down into your heart, and it just tries to regulate your heart rate. It stops your heart from going too slow. It doesn't stop your heart from going too fast, it's purely just to stop it from going too slow. ICD defibrillator is there if you're at a risk of high, fast heart rhythms that can lead to a cardiac arrest, and it will deliver an electrical shock to get you back into a normal rhythm. And CRT is a heart failure treatment device to try and help your heart beat in a more efficient manner. There's lots of different intricacies, and unfortunately we've only got 20 minutes, so I can't go into everything I would tell a patient about devices, but just a whistle-stop tour of all the different things to consider. Surgery is usually performed as a day case. It's usually under local anaesthetic, and it's a fairly routine procedure for us now. Obviously, it's quite scary if you're on the other end of that. But the risk of complications is extremely low. The surgery is quite easy to perform and routine. Driving, there are restrictions, and your teams will be able to advise you on what those are for you specifically, depending on your device, what you have, and your certain scenario. Lifestyle changes, we hope, don't really happen, but we are aware that this is a device that goes in your chest. It can make people feel uneasy. It can cause all kinds of distress and emotions and anxiety. But your healthcare teams are there to support you. So please use us. Please speak to us. If you're having anxieties about these devices, just speak to us, because we can try and signpost you to different support networks. And follow-up's lifelong. We, as device teams, are there to help you. Please use us, because that's what we're there for, and that's what we enjoy doing. That's why we do this job. Thank you.
Thank you. Has that got mine up now? Is that right? Fab, thank you. Hi, so my name is Jennifer Taylor. I'm here with many hats on today. I am a patient. I have dilated cardiomyopathy, and I've had a lot of the devices that Jamie mentioned before. I've had cardiomyopathy my whole life, and device therapy since I was 16. So I've sort of walked the walk and learnt to talk the talk later, basically. I also am here as an academic researcher. I am completing a PhD looking at the lived experiences of newly diagnosed patients and how we can sort of use those experiences to inform future care and improve care for new patients. But my day-to-day job at the moment is I'm an assistant clinical psychologist at Liverpool Heart and Chest Hospital. So I work with patients with chronic illness, currently not cardiac patients, but other patients with chronic illness in terms of coping and adjusting to life with chronic illness. So there's lots of ways that having a device might impact your life, and there's lots of different things to think about, and some people won't have any of these things, some people might have all of these things, and it just affects everybody differently. We can feel very differently about having a device, and the impact of having a device can very much depend on why the device was fitted and your journey to getting a device. So for some people it's the logical next step in their treatment. It's a development of a plan or an ongoing diagnosis that they've had for a long time. And for other people it's because they've suddenly had a cardiac event like a cardiac arrest, that then they needed to have this fitted, and they've suddenly got a diagnosis potentially along with that as well, of cardiomyopathy or with something else. So all these things can change how we relate to our condition, how we think about these things, how we cope generally with these changes. Yeah, so there's lots of common worries, and people living with devices, especially ICDs, will have various different things that they're concerned about. A lot of it is the, you know, the whole, what will it feel like if I have a shock? That's a very big thing that people worry about. That's something I definitely worried about myself when I had an ICD. I had an ICD fitted at 18, and I was extremely anxious. And I've learned since that time, obviously through my career, the skills needed to cope with that anxiety and to deal with that better. Whereas I think early on it was very much something that took over my life. So I've kind of been there and seen what it can do to people's mental health firsthand. There's also obviously the physical consequences, uncertainty, the fact that it's, you know, your life in the hands of a machine, all of that kind of thing. Some people get very funny about using their arm after surgery. I'm doing it this side, normally it's this side, but I've actually got mine on the right now. But yeah, some people, you know, worry about moving too much, damaging it, pulling leads, that sort of thing. And your world can get very small very quickly if you start to avoid things due to anxiety or worry. So I just wanted to briefly say, you know, why do we worry? What is it that, what's the purpose? Because it doesn't seem to have any benefit to us. But actually it's an evolutionary response, and it was developed because in the caveman days, obviously you needed a threat system inbuilt into your brain to tell you and alert you when there's a risk to your safety. And so sometimes when we have these experiences, say we've had a cardiac arrest, or even just the process of going into theatre and having a device fitted, it can trigger those that threat system in our brain, and that then causes you to have a physical response, which can lead to signs of anxiety, heightened, which I've put here. So heightened awareness, tunnel vision, dizziness, heart pounding. This is called your fight or flight response. And some people might have a couple of these things or just one of them. If you have a sudden onset of all of these things, that's when we decide that you're actually having a panic attack. And it can feel like you've just been completely consumed by a wave of panic, which is not a very pleasant feeling, but it's because of this mechanism in your brain. It's there to serve you and keep you safe. So it's all about, in terms of managing your anxieties, it's all about learning why things are happening, why your brain's doing this to you, why you're feeling this way, and trying to implement some strategies to combat that, so relax your system, and so it can feel safe to switch off. So I think one of the things with having a cardiac issue is that a lot of the symptoms that we get can sometimes either be mistaken for anxiety, or can equally, you know, you can have these symptoms and you start to experience them, and all of a sudden you're very hypervigilant about any symptom that you've got, and you start to think, I've got breathlessness, and, you know, maybe your fingers are starting to tingle because you're hyperventilating, and then you think, oh, I've got a heart condition, I'm very aware I've got a heart condition, and now this is, maybe my device is going to go off if I've got an ICD, or, you know, and I start to think something's wrong with my heart. But as you can see, the physical manifestation of anxiety is very similar. So sometimes it's about stopping and pausing and acknowledging that you're having this flood of physical sensation and trying to actually work out, is this anxiety? Is this my heart condition? And really sort of understanding where that difference lies is quite a skill to do, and it's something that you will learn over time. For people who have just started out with their cardiomyopathy journey, it's something with a chronic condition that you, obviously as you get to know your body and how things feel over time, you get better at recognising those things. So I just wanted to put this slide in because it's, you know, people think adjustment over time when you have a device. It is an adjustment, and over time you think, well, I'm just going to make small incremental gains and I'll get to where I want to be, which is back to where I was. And actually, the path often looks very different. It often looks like the second one here, where we can take 2 steps back. Sometimes we feel like we're finally getting there, we've gone back to doing things that we like, but maybe we can't do them as well, or we've been deconditioned, we've been out of exercise for a while because we had to stop, and while we had the procedure and recovered, and now things are a bit different, or you can't push as hard, or you can't compete anymore, and that's really hard for people to adjust to. So it's about, you know, having that acknowledgement that it won't always be a straight path forward, and there will be ups and downs, but over time the general gist is that you will get there. It's just going to take some time. So I've got here, this is the model we use when we're sort of engaging with therapy or providing psychological support with people. This is one of our CBT models. So it's just to illustrate really how, and it's nothing that anyone doesn't already know. It's very sort of, everyone does this anyway, but it's just highlighting it that, you know, if you have a thought or a negative thought, a challenging thought, a difficult thought to deal with, that can then evoke certain feelings. And those feelings can trigger this stress response in your body. So if you're, you know, saying, oh, you know, what if I push myself too far? I don't know how much I can do in the gym anymore. I'm really scared. I don't know. That then is obviously a lot of worry, a lot of frustration, a lot of fear, which then might mean that you stop doing that activity. You might avoid going to the gym. You might not take your dog for a walk, you know. And the result of that, the consequence of that is that your world gets very small. You stop seeing socially the people that you always saw at the gym or on your walks. You stop having that connection with your dog or with nature or whatever it is that brings you joy each day. And so it's about sort of acknowledging that if we change the initial thought or we stop and challenge that initial thought, then what happens is these consequences will change as well, and it'll feel a little bit easier to cope with. Yeah, so having a health condition can feel a lot like the lady in the picture with all the suitcases. So you've got one suitcase, which is your cardiomyopathy or your diagnosis, and you always have to lug that with you wherever you go, and it is a heavy burden to carry. But what we don't want to do is keep adding suitcases on top of that: stress, worry, anxiety, difficult thoughts, things that are ultimately going to make it heavier for you and more difficult for you to move forward. And I've put the little compass here because I think it's really important. Part of the work that I do in therapy with people is to identify what your core values are. Because ultimately, living a happy and fulfilling life means living, you know, navigating towards those values and always orienting everything that you do to make sure that you can still live by those values. And it might look very different how you do that. So the example I always give, so a core value for me when I was in my 20s, I wanted to make sure I still had a lot of sort of fun times with my son, and I wanted to be able to safely look after him on my own without having to worry about other people supporting me too much and him seeing that I'm not able to engage with him. So I would sit him on my knee and bump down the stairs after bath time, and that would safely get him down the stairs, and it would be our little moment of connection and fun. And when he got older, it was a case of we'd race each other bumping down the stairs, you know. And it's something that I always use an exact example of how to, you know, change our behaviour slightly. So we're still living towards our values and we're still able to live a full and happy life. But we might have to adjust the way we're doing it or to how we did before. So I've just put this technique here, we call it dropping the anchor. So basically what we try and teach people to do, and it's not an easy thing to do, it's very difficult in fact when you're caught up in emotions, to stop actually and recognise, okay, I'm having a feeling that. And that's really key, is that skill to be able to say, okay, I am feeling overwhelmed right now, I am feeling really frustrated and every little thing is irritating me. You know, really sort of recognising that, stopping, take a little breath, come back to your body. Sometimes we like to say about grounding techniques, name something you can see, name something you can hear, name something you can feel, anything that brings you out of your head space into your body space. And that can help to alleviate this threat system as well and calm your nervous system down. And that will stop some of the symptoms, which then stops the worry that there's something wrong with my heart. You know, and you just break that cycle. So yeah, we like to observe our thoughts. Why am I having this thought? What is it I'm doing right now that is exacerbating this? Why am I putting so much pressure on myself in this moment? Let's stop and think about it. And then proceed mindfully. So mindfulness is all about being in the moment, and I'll talk about that in a second. But yeah, so the point is to always acknowledge, come back to your body, and then carry on and still engage with what you were doing, but it might be in a different way. It might be to a lesser extent than you were going to. So mindfulness is something we use, and it sounds a bit hippy-dippy to some people, and it can be a really difficult thing to get your head round. I certainly was a bit like, really, initially, but it works at the end of the day. I've had some patients say to me that, I wasn't sure about that, you know. Whereas now they can see that if they get overwhelmed, they can do something as simple as go to the window and look outside and just have a mindful moment, as we call it. And you can do mindfulness in anything. So basically, it's all about just coming back into the body space, just really grounding yourself and being present in everything that you're doing. So it could even be as you're having a cup of tea. You can feel the ceramic cup on your hand. You can feel the warmth of that. Really focus in on those things rather than in your head and what you're thinking about. And just for that couple of minutes, to just take yourself away from all of those thoughts and fears and anxieties and stress that you've got going in your life, and just really focus on that cup. It smells like this, it tastes like this, everything that you're worried about, just let it drip away for a couple of moments, and again, that threat system is deactivated. Obviously, there's lots of different things you can use. There's body scanning techniques, there's different exercises, loads of things on YouTube. If you ever want to, you can go for a mindful walk. You go walking around the forest, there's a good one where it says about talking about connecting with nature and being in nature and trying to, again, just switch off from all that stress so that you can reset. Top tips, I would say, what helps you to cope? Does that look different now to what it did before? Early warning signs, so just make sure that you're aware of the things that are going to trigger you, the things that are going to set off this threat system, whether you've got a aversion to hospital since your traumatic event, whether you think, I've got to go to hospital next week, and you can just feel yourself all week getting built up. Being able to identify that and recognise that so that you can implement some strategies to help you to cope. Practicing mindfulness, even if it's, like I say, just have a cup of tea, go stand outside, taking a deep breath, anything you can do. Self-care and self-compassion, I think that's a really important one. I think a lot of people find it very difficult to look after themselves. They might put everyone else first. And we can be quite critical of ourselves and quite nasty towards ourselves. Nothing we do is good enough. We always compare ourselves to how we once were or to someone else. And it's the sort of thing where you have to think to yourself, what do I do? What would I say to a friend in this situation? Because half the things you say to yourself, you wouldn't dream of saying to someone else. So it's just about being mindful of the impact that has on how you feel about yourself, and to just be kinder and move with some self-compassion. Tap into your values and engage in these value-based activities. Again, it's really helpful even if you just sit and have a think. One of the nights, if you're up worried about something, just say, okay, what are my core values in life? What is it that's really important to me? That no matter what is happening, no matter what's going on with my heart condition, I need to be able to do these things in order to live a fulfilled and happy life. And then you can start to strategize different ways that you can do that, even if it is different to how it once was. And connect with others. That's been a big theme throughout the day today that I've heard is how important it is to make sure that you have got connection to other people, whether it's people that share your experience, share your journey, or whether it's someone who's supporting you physically, emotionally, family, friends. Make sure you stay connected. And I've put base formula here. It's just a case of one of my friends at work actively does this every week, and I think it's great, and I think I might start it. So you just have to make sure you're doing something each week or each day, whatever you've got, that's looking after your body, something that makes you feel like you've done achievement. I've put a load of washing today, yay me. That sort of thing. Make sure you recognise your achievements. Some connection, connect to nature, connect to your dog, connect to another person. And something that brings you joy, because we've got to enjoy life, haven't we, at the end of the day. So, stick a Christmas film on, that's brought me joy this week. So that's me done.
Thank you. Would you both like to?
Yeah.
So we've got, like I said, we've got a few on the app, but maybe we've got some questions we can take from the room as well. But yeah, thank you both. It's really interesting. Have we got any questions in the room? Yes, sir.
Afternoon. I've had an ICD for 8 years. This year I went up to the NEC. They have the security barriers you go through. I was now told we can go through them, they're ICD proof. I wanted to listen to the experts first. Have they changed them or are they still the same?
They may have changed them. The key thing is, the reason we say don't go through them is because they usually have a magnet within them.
Yeah.
If you have to walk through them, and if they say, yeah, it's ICD proof, all the rest of it, just do it. Because actually the risk of anything happening to you is extremely low. The magnet is only going to deactivate the device or change the pacing of the device for the moment that you're in contact with it as you walk through. So if you walk through, just one step through, it's not going to have any impact whatsoever. Ideally walk around it, but again, we've not known of anybody have any issues walking through, and more airports around the world are saying, yeah, just go through it. But the key is just don't stand in the middle of it for a few minutes.
And induction cookers, are we allowed near them?
So technically, you should avoid induction cookers. This is a question we get a lot at the moment. However, what I say to people is, if you've got an induction cooker at home, you haven't got to get rid of it because that's a huge expense. Really, if you've got a device and you've got an induction cooker, you're going to have to sit with your device over the top of it. Most people are not going to do that. In fact, I'd hope everybody. Yeah, carry on using it. Just be mindful of it. So when we have any magnets, we always say 6 inches away. So if you're standing here cooking, you're fine. You're not going to put your chest on it and cook yourself, so you'll be all right. All right.
Did I have another question? Yes.
When you talked about the CRT, did you say that included a defib?
So it doesn't have to. So there's 2 types. So there's a pacemaker type and there's a defibrillator type.
Okay.
So some people, the pacemaker type is absolutely fine. The defibrillator type will also do the pacing, but it just has a defibrillator on it as well. And it just depends on you as a patient as to which one is better for you, your condition.
And that's a similar sort of operation, local anaesthetic?
Exactly the same. They're both, yeah, it's exactly the same procedure. The only difference is that the lead for the defibrillator is just slightly thicker, but not that you're going to notice.
And is that usually all inside you if you
Yes.
have a CRT?
Yeah.
Okay, thank you very much.
Okay.
So this is, my husband has a ICD. He's gone to another session. I'm his voice. When it goes off, and it has, unfortunately for him, the thing that was most unpleasant about that was the audible alarm that went off the next morning at 7 a.m. before either of us had woken up. And I just want to advocate for not setting it at 7 a.m., but maybe having it for around 11s when you're both up and I can see that he's well. Because we have now had it reset time-wise, but it went off every morning at 7 a.m. until we were able to go in and get it reset. So it's just a little advocate for you as a technician, please, to set the alarm for in the middle of the day.
That's really good feedback. I think most of them are nominally 8 o'clock now. It's still quite early, isn't it? I think a lot of us try and program it at a time when you're going to notice it as well, mostly because nowadays we have lots of different appliances around the room, so you might have your microwave going off, you might have something else, and it's trying to just hone in that this is the actual device that's causing it. But no, that's great feedback, and I think we try and make people aware that the device has these alarms, and there's lots of different reasons for the alarms. It's not just having a shock. But it's good to actually speak to the clinic and get them to demonstrate it to you so you can hear what it says. And if you've got a preference on when you prefer for it to go off, absolutely tell them as well. Mm-hmm. Absolutely.
So slightly the follow-up on that is, we didn't know there was an audible alarm in it, so that's the other thing I suppose I would say. So it is quite useful to know that. And you can find the audible alarms, for those who've never heard it, online. And then my husband, who has a great sense of humour, does like to play it to me intermittently.
Yeah. So it has an alarm because the device wants you to speak to the healthcare centre so that we can have a look what's going on. There's lots of different reasons for an alarm. One is that you've had a shock. One is that the battery may have an issue, but there's lots of other things that are kind of less important as well. Like one of the measurements may have gone slightly out of range. Frustratingly, one particular manufacturer has it on, if you don't speak to your home monitor within 14 days, it likes to alarm. And we can't change that one, unfortunately, but that's a really annoying one as well. So the key is, if you hear an alarm, don't panic, because it doesn't mean anything is immediately going to happen. Just call your centre at the earliest convenience, and we'll be able to see what's going on, tell you what's going on, and advise you to get it turned off as well.
I'm just going to take a couple on the app, and then we'll come back. I can see there's some arms up, or hands up, sorry. So which people with cardiomyopathy, benefit most from an ICD?
Okay, good question. So I don't think there is an exclusive group that benefits most from an ICD. When we're deciding whether a patient will have a defibrillator or not, there's lots of different characteristics that will push us towards that decision. And typically in the cardiomyopathy group, we use risk scores to try and calculate that. So you might have things like blackouts, there may be something to do with your condition that puts you at a slightly higher risk of an arrhythmic event or a heart rhythm coming from the bottom chambers of your heart. So when we decide on a defibrillator, it's not a likely choice that we make. We usually get a lot of background data on you as an individual. We would decide, based on a risk score, what is the likelihood that you're going to have one of these heart rhythms, and that will push us towards that device. And that isn't, this is a healthcare professional, you need to have it. That's then to lead us to a discussion with you, because having a defibrillator is also not for everybody, because it can cause anxieties, it can cause all kinds of different things that you may not even think about initially. So it's about having that discussion with you as a patient and saying, is this what we want? This is what it's going to do. Is this what you want? And that would lean us more towards that kind of route.
One more on the app. What is a safe and beneficial level of physical activity or exercise for people with cardiomyopathy?
So it depends person to person. It depends a little bit on your diagnosis as well. The best thing to do is speak to your healthcare professional, because they'll be able to advise you. Most people, we want you to do as much as you can, because actually exercise is beneficial. It helps you maintain a good lifestyle for as long as it can. So for most people, a good level of exercise is appropriate. And it's a case of building it up gradually rather than just going, right, I have my ICD, I'm going to go straight to the gym and going to lift 200 kilogram weights. It's about you as an individual, building back up to it, doing what you can. There are some conditions that it might not be appropriate to exercise until the right treatment's been started. So for cardiomyopathy particularly, it's worth talking to your consultant or your nurse or your medical team, because they'll be able to give you specific advice for you. Okay.
Hello, it's been really, really interesting, both of you, thank you. I wanted to ask about the future, because it was mentioned in a different group about a micro pacemaker, and I just wondered what the future brings.
Yeah, so the future's quite open at the moment, and there's lots of development work going on. We have started to see devices without leads, such as the Micra, which is just a very, very small device. It's a pacemaker, and it sits within your heart, but it has no leads connecting up to a box. We've seen the move to S-ICD and more wireless treatments as well. But at the moment, there's not been any huge pathways forward. We don't really know where it's going to go, because all of these technologies have their advantages and disadvantages. The Micra device, 10 years ago when it came out, the leadless device, was the be-all and end-all. We all thought that was the direction it was going to go in. Nowadays, we're not overly sure, because with that, it comes with different issues, particularly when you need CRT and you could potentially have 3 of these devices. So it's going to need 3 different batteries and things like that. So we don't know exactly where it's going to go. All we know at the moment is that we've got these devices out there with the leads and the boxes. They've been around for 50 years, and they've done an awfully good job of that. I think it's going to take something quite big to move away from that. I think that the devices will get smaller, the batteries will get better, we'll have more remote technology with remote monitoring and things like that. But at the moment, certainly within the next 5 to 10 years, I don't think there's going to be any dramatic movement from that. But who knows? Yeah, I think that seems to be the best at the moment for most people. So it's been a stable thing.
Sorry, I'm going to be a bit greedy. I've got 3 questions. But my first question is, So I'm having my ICD fitted next week.
Wow, okay.
But annoyingly, because of the Christmas period, I'm not being seen for my follow-up until mid-January. Obviously, they say like a 4 to 6 weeks recovery, but I won't be seen for a lot longer. I'm just wondering if, like, during that time, I can not sign off my own recovery, but, like, you know, once it gets to the 6 weeks, kind of at what should I be looking out for to be like, okay, I can finally move a little more.
Yeah.
And then my other question again for you was just in the follow-up appointment, what kind of key questions should I be asking with regards to like the settings on my device and things like that?
Yeah.
And then finally for you, Jenny, in terms of psychological support, what is there available? Because to be honest, that's the thing that I found hardest. And there hasn't been any. So yeah, just wondering what there is.
Absolutely. So,
You go first.
yeah, of course. So the ICD, just, sorry, remind me of your first question.
I'm having an MTB ICD on
Yes.
next week.
Yeah.
The follow-up period.
The follow-up, oh yes, of course. Yeah, yeah. So with that follow-up period, generally 6 weeks recovery is okay. The main things we're concerned about is the wound and the healing up of the wound. So the key things to watch out for is just make sure that you get some wound advice when you get discharged. Make sure that it's starting to heal up. If there's any signs that the scar is opening up again, or it starts to look red, angry, inflamed, it's painful after a couple of weeks still, then get back in touch with people earlier. Typically nowadays, we hope, it depends a little bit centre to centre, that we'll give you home monitoring as well to start with. And generally that will be alerting us if there's a problem before we see you in the clinic. So you'd be absolutely fine for that extended period. If you start to feel unwell during that period, or it just doesn't feel right, then just call us and we can advise you over the phone and say, okay, try this, try that. We need to see you a little bit sooner, but most people are absolutely fine. If it's just a straight ICD, to be honest, you're probably not going to notice anything because it's just sitting in the background and watching you, and hopefully it's going to do that forever. So you might not notice anything else, but if you do and you're worried, just call to help. In terms of what was...
So just any, like, because I see a lot of people obviously on forums and stuff saying, when you go to your first follow-up,
yes,
talk about your settings and blah, blah, blah. So I'm just wondering what questions I should be asking and how to approach that.
I think the key is when you get discharged, they're going to give you loads of information, and it's just a case of live your life a little bit during those 6 weeks and see what works, what doesn't work. You don't really need to be asking many questions. You can. Different people have very different approaches. Some people just want to be ignorant and not know anything. Other people might not want to know at what points it's going to kick in, what treatment's it going to give to me. So those are the things that you might be able to ask. What's the settings? Some people get reassurance by knowing, okay, if my heart goes faster than 200, that's when it's going to shock me. You could ask about the battery, and how long the battery life is going to last. So devices typically last around 10 to 12 years. And after 10 to 12 years, we replace that box. And Jenny's had a few of those, so she'll be able to give a bit of experience. And we generally replace that box with a new one. So it's always worth asking, well, what's my battery life going to be? 10 years from battery is fantastic. So if we got those from smartphones, we'd be quite happy. So typically, they're going a bit longer now, so you might even get 10 to 15 years, depending on what you're having. Does that answer those questions? Okay.
So in terms of psychological support for people getting a device, unfortunately the answer is there's not enough. And it's very much depending on where you live and what your NHS trust has to offer, what funding they have. It's a bit of a postcode lottery, unfortunately, and it's something that is improving. I think there is more of an awareness that particularly ICDs, but all device therapy comes with a lot of lifestyle changes, a lot of psychological adjustment that is needed, and patients need support with that. So at the hospital where I am, obviously I'm at a tertiary heart centre, so it's all about the heart, and they have a psychology service embedded in the hospital itself. So when you go to cardiac rehab, if you're offered that after surgery, which is like an exercise program to build up your confidence with exercise post-surgery, sometimes we're embedded in that service in the community where it's a sense of go and build up your confidence, speak to a nutritionist, speak to a psychologist. It's all there in one thing. Sometimes it's a case of they will have ward support. So if you're admitted onto a hospital ward, that there might be someone that would come around and talk to you and check how you're doing, and you could access the service that way. It's very much dependent on the service that you've got. If you want, we can have a little chat later in the break. But yeah, there's lots of other services that aren't heart specific, which I always felt was kind of, you know, it's not what you want. You want someone that understands exactly, but they're good enough for, you know, obviously they understand chronic illness. So as long as it's not device specific, they can help you in terms of adjusting to life with a condition or get your head around anxiety or low mood more generally. Hope that answers your question, okay? Yeah.
Thank you.
I think just to add to that, I think the key is ask what's available, because it's very different. So some have got support groups specifically for devices.
Yeah.
There's Facebook groups out there for
peer support as well.
Peer support.
There'll be someone else that have had a device, had multiple shocks, that can relate their experience and have a chat with you.
If there's something specific that's bothering you, speak to the team on the day, and they might be able to signpost you to the right things and try and help where they can.
Yeah.
Just to say, and like Cardiomyopathy UK, we've got support groups and an amazing helpline and lots of staff outside. So if you wanted to talk as well, they're there for you. Okay. We've got one more question. I know we're slightly eating into our coffee break.
Jenny's partly answered my question, but I'll say what I'm going to say anyway. But in June, I was admitted because through tests they picked up my heart paused for about 11 seconds, a few nights on the trot, so they whisked me in, and I came out with a ICD pacemaker, which was great. I went back after my 6-week review, and they said, "This is fantastic. You're not going to die, and you can do whatever you like." And I found that really difficult because I spent the last 5 years controlling my life, controlling my exercise, talking to people about it, and I almost felt like some kind of a survivor's guilt. It wasn't quite that, but you know, you're a patient and you've got all these things, and suddenly you're set off. So in terms of what to do, I went to the ICD groups, the Zoom groups, I've done the HCM group. I've also got an ICD nurse, which I can call, which is brilliant because I get a reply in a couple of hours, and before I'd have to wait months.
Yeah.
But I was saying that changeover you talk about is really quite strange.
Yeah. Because
instead of being incredibly positive, you suddenly think, oh dear.
Yeah, and it's another period of adjustment, isn't it? It's like that graph before where we kind of, you know, it's a very much up and down journey, and things will happen, and things like that will surprise you. You kind of think, well, this is good news. So, for example, at work, where I work, there's a cystic fibrosis service, and a lot of people in that service are very young, and they kind of come to terms with the fact that obviously they've got a very life-limiting condition, and they plan for not living as long as everyone else. But now there's new medication that is actually improving their lung function to a point where they could live into their 80s. And a lot of those patients are, like you say, well, what do we do now? I wasn't planning for that. You know? And it's really, it's a confronting thing. It's really difficult, and it's another adjustment, isn't it? And it's another loss, if you like, of the person you were before that event. And it's going to have a profound effect on your mental health as you go through that process of adjustment.
But I've always done a lot of exercise.
Yeah.
Now I can tell it back, and I've got to make judgments about what I can do and what I can't do. And
yeah, it's learning that sort of considered approach to living by what's important to you. So if you want to carry on doing your exercise, absolutely do it under the supervision of your clinical team and going by all the recommendations. But yeah, there's a path forward, and there's always a way to do something, even if it's not the way you're used to. Yeah.
I think we may have another question, or is that okay?
Fine,
we've got slightly over. We've got a lady up here that's had her hand up. Oh, sorry, I saw a hand here.
Very quick question. Yeah, I went to the pacemaking department to have the checkup. I've got a subcutaneous ICD. So she said, oh, it's got plenty of juice, that's fine. But she also said it loses about 20% a year, which to my mind means it has to be replaced in 5 years. But the literature says like 7 to 10, and you were saying a bit longer than that possibly. So how much juice does it need to be effective?
Mm-hmm. It's a really good question. So typically the S-ICDs are a little bit shorter, so they are about 5 to 7 years at the moment, but they are improving. The key thing when it comes to battery is we always work to a safe point, and that safe point is what we call elective replacement. So that 20%, 50%, 40% is to that elective replacement point. So that's not zero. So when it hits 0, it then usually has at least 3 months or 6 shocks or whatever it is for that device to carry on as a safety point. Batteries are unpredictable and they do change depending on what device you've got, what age of device you've got. And that's where our kind of specialist knowledge comes in and how those batteries behave towards that end of life. So if you've got specific questions, that 20% seems an awful lot. Actually, that is probably normal for your device, but speak up and ask, because actually the physiologists, it's our bread and butter. We love talking about it. So please ask loads of questions when you come to clinic. And if you're concerned about your battery, we'll be able to reassure you, because we work to very strict safety points to try and help with that. So it will still function pretty much until we change it, unless we go way beyond that point, so which we hopefully won't.